Now, as a follow-up, the supraglottic airway, you ran out of them, everyone threw away, you're having difficulty intubating, right? So perhaps this patient, the seal is bad, you don't have the appropriate size. You're trying to intubate, right? You notice I'm not hunchbacking. Staying orthotic, squat, right? See the tube, perhaps. I can get the tube in. Maybe I see a demon's airway. Maybe I see nothing. I use my ELM. I still see nothing. I see darkness. If it proves that I can't pass the tube in, and someone mentions something, do not get butthurt. When someone mentions a surgical airway, it doesn't have to be only traumatic airways. You can have medical emergencies that require this. And if it happens at the airway, you don't have a supraglottic airway, all you have is a BVM with a face mask. And it wasn't working. And you couldn't tube the guy with traditional laryngoscope or the glorious glide scope or some video laryngoscope or McGrath device. Even with my King Vision channel device. If you fail that, there's an airway you can do anywhere you are in the world. Cardiac arrest, traumatic arrest, a surgical airway. You already thought of it and should have been thinking about it when you said, I'm going to give paralytics. But if the guy has no pulse, very rarely you'll need to give medicines that the CPR is providing enough adequate perfusion that the guy is clenching down in his jaw. Very rarely it happens that you need to give paralytics for that. Most patients are dead or almost dead. Their spirit is floating. They're already seeing the light. The Grim Reaper already saying hi and writing the death note. You understand that? A surgical airway, if the other person does this, a pause to the answer, how come we don't do a surgical airway? It's because of the reasons I taught everyone in airway in my courses. He's thinking of a lie of why he doesn't want to do it. He has no good reason why he's not doing it. And he's scared to do it because he hasn't done it in public and then only thought of it and read about it, watched videos of it, or did it on a cadaver lab or mannequins in his career. And maybe as a PGY 17 is the first time he got to do an airway, a surgical airway, but he's been practicing all his life for it. I've probably done over 200 to 300 sim airways, and I've only done 2 live patients. And I've done cadavers, but 2 live patients as a PGY 22. Again, if you ask someone why you don't do surgical airway, and you haven't paralyzed them, but he's in cardiac arrest, but you can't get the airway, you don't got a supraglottic airway, and you're bagging him, which is low level, basic level of oxygenation, you want a definitive airway, regardless if it's traumatic arrest or cardiac arrest, non-traumatic arrest, you can do a surgical airway. But again, if there's a pause, it's a lie that you're coming up with why you're not doing it. Second, you don't have the lie, and you're scared of doing it, and you think of it as a procedure because you failed other things, and you think of yourself as a failure. And out of pride, you don't want to commit to it because your glide scope, you want to try it again, or trying to use your Miller blade with the bougie for the first time, which I don't recommend using for the first time if you stink at it. The supraglottic airway, you didn't have it, you didn't look for it, right? Stop coming with excuses to kill a patient who's already dead. If you can be a good resuscitationist, do what you have to keep the patients alive. Forget about the pride. And if someone mentions it and it sounds like a good idea, embrace the suck. Embrace the suck that day you couldn't get a supraglottic airway in. Maybe your technique was bad, or maybe his anatomy was bad, or you picked the wrong size. Maybe you shouldn't if you taught well and paid attention. Maybe your intubation skills that day were you sucked, or his anatomy was that bad. Perhaps someone else tried it and be like, "Oh, I couldn't have intubated that either." You should watch on the video laryngoscope on the monitor, like, "Damn, I couldn't get that too." Maybe I got epiglottitis, redundant airway, difficult airway, lingual tonsillar hyperpilation, the Baba Yaga, the John Wick of airways, right? Sometimes maybe the simplest procedure, like a surgical airway, just needs to overcome the most difficult obstacle. You. Get it in, get them alive, and that's how you impress everybody in the world. And the only person that really matters in the room right now is you the patients, the family, and your team members right there trying to do their best to save that patient's life. Your pride, your lack of training, your ego can prevent this patient from surviving. If you get rid of the ego, the ego and pride of failing, and embrace that someone else mentioned this idea, and you were able to possibly save the patient. Not when he's really, really dead an hour into the resuscitation, but when he freshly lost his pulse and witnessed arrest in front of you. Understand that? This also works, the surgery, when you gave the paralytic and failed, you knew there was a backup because I taught you. If you give paralytics, you better think of doing a surgical airway. And you no way you're an emergency medicine doctor, in my eyes. If you don't think of it, consider it, and do it when it's time. Understood?